There's obviously a lot more overlap between neurology and cardiology as the neurovascular field has progressed. We're now doing more procedures and things similar to cardiologists, and obviously the importance of fast action also is much different than in the past. I have some colleagues in neurology who say, I went into neurology so I don't have to rush around. So the field of stroke has kind of had a subset of providers who sort of like that excitement and the urgency involved in that. So in the document I provided and on our website on dhmc.stroke.org or stroke.org, we have this information. And I'm going to talk about what we thought were the more important things to know about stroke, not just prevention, but related to treatment of stroke. So the first thing I'm going to mention is what is a stroke a little bit, then about the warning signs of stroke, what to do if there are possible stroke symptoms, and what increases your risk, as in cardiac disease, but also what causes stroke. And this is where I'm going to highlight some of the differences between stroke and heart attack. So the first thing we do in the document is just try to explain what is a stroke. And basically, as some of you may know, there are two basic types. One is an ischemic stroke, which is when a blood vessel in the brain is blocked and brain cells are damaged because they don't get enough oxygen and nutrients. The other type, which is about roughly 15% or so of all stroke, occurs when a blood vessel ruptures and brain cells are damaged by the pressure of the blood. The problems experienced after a stroke are the result of the brain damage. The specific problems you feel if you've had a stroke are related to the parts of the brain damaged by the stroke. So these problems could include many different things because the brain has areas localized to different parts, and stroke can affect almost every part of the brain. And these things include being unable to move one side of the body like you could before, numbness of one side, problems with your speech, or visual symptoms. So I'm going to highlight some of these. Obviously, though, stroke is a lot more than these kind of definitions. So this is just a picture of all the cascade of things that happen in the brain, starting off with a blocked blood vessel. So the point of this slide is to indicate how a whole lot of biochemical reactions are occurring simultaneously that eventually end up in cell death down here. So a lot of things related to inflammation, damage from toxic molecules and things like that are rapidly occurring. And this is part of the reason why it's been very challenging to minimize the damage of a stroke, because there's not one like silver bullet to prevent the damage. So a lot of these things are also occurring in the heart as well, but to different extents. And the brain has different types of cells, white matter, gray matter. They have different types of chemical reactions that are occurring when they have ischemia. So it's been very challenging, and we still are not very successful at blocking these things to prevent damage in stroke. Obviously, a part of stroke is the obvious results. This is just to show you a little bit about the imaging we do. This is a CAT scan of a very large stroke. This is the left side of the patient's brain, and this is a few days after they had their stroke symptoms. And obviously, there's a whole set of consequences of stroke related to the patient and the impact on their social function and their whole family, as you know. So I'll embarrass her, but we have some people from our stroke support group here. Linda Wilkinson is the leader of that group in the back there. So she's always looking for some new people to join. For some reason, people don't like to go out in minus 14-degree weather. So there's obviously a lot to stroke beyond the emergency room phase. And so we're trying to help people as best we can with dealing with the consequences as well. So I'm going to move on to the warning signs part. In our handout, we tried to use pictures and icons to highlight these symptoms. The usual important word for these is the suddenness, so sudden numbness or weakness on one half of the body. It can be the face, arm, and leg, or all of those together. There can be sudden confusion, trouble speaking or understanding. There can be troubles with vision, as this indicates. It can affect one eye, just with the vision, or it can affect the visual field all on one side of space. This is meant to be sudden troubles walking or dizziness or loss of balance. and also some types of stroke produce primarily a sudden severe headache that is different than what you've ever had and without another cause. The medical field has struggled with trying to help people recognize stroke and keep it simple enough, because as you can see, there's many different symptoms. Some of those are very nonspecific, so dizziness can be caused by many different things. So they tried to prioritize the message, but it's been difficult to have it be clear but also specific. You can see here from the American Stroke Association, they have, like many other organizations, simplified this to the FAST mnemonic. So this has to do with the facial droop, the arm weakness, speech change, and then emphasizing time and how that's very important to call 911. So there's an app that shows this. I was looking at it, and it shows you the different parts of it, and then it lets you call 911 and put in the time that you notice the symptoms right there on your phone. I'm going to play a little public service announcement that some of you probably have seen, but it just highlights these symptom recognition part. So.
Body language. Without saying a word, it can tell you so much. Like someone is having a stroke. Know the sudden signs. Learn fast. F, face drooping. A, arm weakness. S, speech difficulty. T, time. Time to call 911 immediately. The sooner they get to the hospital, the sooner they'll get treatment. And that can make a remarkable difference in their recovery. Learn the body language, sudden signs, and spot a stroke fast.
Feel emotion. It's very emotional, well done ad that they've had there. They have a series of those. So related to the message they gave you there, I want to talk a little bit about what to do if there are symptoms. Often it's in someone other than yourself. It's important for the public to know this. So in our handout, I just highlighted a few of these for emphasis. Obviously, we try to emphasize not to ignore signs of stroke. This is common. Sometimes it has to do with the part of the brain affected for the patient, so that makes them not be aware of the symptoms. But we also all know that it's very hard to pull the trigger to call 911 when someone's having something, you're not sure what it is. The other thing is to check the time. So it's very important for the doctors to know when things were noted or not noted. That can be very hard in the middle of a crisis. We emphasize the importance of calling 911 because that gets attention and gets you triaged faster than if you come in by car. And finally, to use the word stroke if it seems like that might be what's going on. So the importance of calling 911 is multifaceted, but I wanted to highlight a couple of things. So you've probably heard of this expression, might have seen this picture of the brain sort of dissolving over time here. So this expression, time is brain, is really true. And when I have a patient with a stroke, I encourage people to sort of try to visualize that, because often the patient is not complaining, they're not having any pain, but we have to think about this. The UK has a similar FAST PSA where they show the patient having like a fire that's visible on their scalp as a way of trying to emphasize that. But I think that's part of the problem with getting stroke treated fast, is it's not really apparent that the damage is going on. So with a stroke, there's a blockage of a blood vessel, and immediately there's all those things happening biochemically causing damage, and this is showing a picture of the final damage that's resulting here. So as I mentioned, all of these things are going on very quickly. So currently we haven't been able to defeat the chemical changes that are all occurring. So we're limited currently to a few things to try to open up the blockage in the blood vessel here, similar to in cardiology. Currently the main medical treatment you've probably heard about is this TPA, or clot-busting medication. So I'm going to mention that, talk about that a little bit. So this is really the only medicine approved for acute ischemic stroke, and that's for treatment within 3 hours from the very beginning of symptoms. So that makes it challenging. Basically, if you look at the outcomes from studies, on average it doubles the odds of having a good outcome despite increasing the risk of a hemorrhage. So this is a double-edged sword to a degree. It breaks up blood clots, and when you're having brain damage, you're at risk for bleeding. So this does increase your risk of bleeding into the brain and getting worse. But even if you take into account that possibility, if you look at a large group of patients that get this in time, it doubles their chances of having a good outcome. And in these studies, what they meant by a good outcome was basically being back to normal or being almost back to normal without any disability. So there are these other devices similar to what might be done in cardiology. We're actually trying to break up the blood clot and remove the clots. So they're pretty amazing, and we sometimes have dramatic results. Sometimes it's too late and we can get the artery opened, but there's still too much damage that has occurred. So basically the time window is sort of longer. It's out to a few hours. These are really only a small percentage of our stroke patients. So this is one thing that sometimes people don't realize. Compared to heart attack, this is a much smaller percentage of our stroke population that have this type of stroke where there's a blocked blood vessel that we can get at, and it's harder to get at the brain arteries than it is some of the coronary arteries, and they're more delicate and there's more risks involved. So this is really only a small percentage. It might end up being, say, 5% that might have this, and a lot of patients aren't at a place that can do this, or they end up getting to a place too late. So this hasn't been the answer for all of stroke, but this is just a couple of examples. This is a patient who has a blocked artery right here. This is in the back circulation, and they were able to put this device here. This is the first one approved. It's like a corkscrew, and you actually pull the clot out there, and they restore the blood flow. These are some of the other devices that have come along after that, and this one is sort of like a little vacuum cleaner where it aspirates out the clot, and this one here is a stent that's opened up and the clot is trapped, and then they pull the whole stent out with the clot. This is kind of the preferred device that's currently been used. I want to emphasize that the time factor is also very critical for brain hemorrhage as well, and this just is a picture showing how this is a patient on a CAT scan. This is all blood, and that was 2 hours, and the same patient 4.5 hours later, they had an enlargement of this, and this would be a fatal type of stroke. So this is fairly common that we see within the first few hours, and it's especially true if you're on blood-thinning medications. So Coumadin, again, it's a very effective medication, especially if you have atrial fibrillation, but as you know, you can have serious bleeding. So there are treatments to reverse the effects of this if you're having a brain hemorrhage, and that has to be administered very quickly. And the other important factor, this is to emphasize blood pressure control when people present to the emergency room. So those are the two immediate medical things that can be done, but this is much different management than someone with an ischemic stroke from a blocked artery. So we can't always tell the difference when someone is coming in. Okay, let's see. I'm going to move down here to keep everyone awake. This was a picture from something that just came out in Medscape, and this was just to show how many people use the EMS to come in with a heart attack and stroke, and it's actually lower than you might think. So this was from the United States, and it's kind of flat from 2003 to more recently. So there was a big database, so it's not up to date this year, but basically it's still about 50% for both heart attack and stroke. So that's a big issue. There might be some justifiable reasons, but it's sometimes not used enough. Now this is a way that some places are dealing with this. If the patients won't get the ambulance, they're going to send the ambulance and the stroke unit to the patient. So this is in Germany and some other centers that have very, very large cities, and the population lives very close to their center. It's also happening in Cleveland and Houston. So that the ambulance is a big truck that has a lab and it has a CAT scanner right in it, and then you can treat the patients. If they have something that could be treated with TPA, they can treat them. In Germany, though, the way things work, they have a physician who always rides on the ambulances in the big cities. So they already have a physician that's always there. I volunteered to do this around here, but so far no one has taken me out. And it would be challenging if someone's, in rural Vermont, 20 minutes from Springfield. So this is very challenging to apply to our area. And we're not going to send the helicopter out to do this yet. This is just one solution that's being used in some of the larger areas. So obviously, we're not going to be able to do that. So there's a lot of little steps starting from the initial recognition of stroke that has to be really coordinated. So that's what we spend a lot of time trying to do. And it's all very similar to the cardiologist and vascular surgeon's work. So this is just to give you a little background on what types of things we try to do to decrease the complexity, make things happen more efficiently. This is just from a group in Vermont that I worked with. So this is just showing how we have a lot of hospitals. A lot of these hospitals are what you call critical access hospitals. They have very limited resources. And we're looking at all the logistical issues with the distance, how to transport the patient. This is just a little chart that helps people be aware of how fast it might take to get from one place to another. And we really can't rely on the helicopter as much as might be done in other parts of the United States because of the weather and things like that. So there's a lot of work going on to try to get our resources together and try to get patients treated no matter where they live. But it's very difficult. This is a list of hospitals that can send us their CAT scans electronically. So this has been very helpful for us. So if we're going to give advice to a hospital outside of our area, it's been very helpful for us to have this technology. So this is one of the things that's happened over the past few years. So if you don't see your hospital on there, it probably has been added, so I don't want to scare you. We're doing telemedicine now. This was just one of the practice cases we did early on, so hopefully it's not someone from the audience. But this now allows us to do a live video evaluation. We also have the CAT scans to look at. So this has been really helpful, but it's still limited the number of hospitals that we're doing this at. You'll hear more about that in the future. This is just an example of how we're trying to get more efficient with our residents and everyone else in the emergency room. So we use the simulation lab you might have heard about, the Patient Training Safety Center. And this is just a picture. We have a professional patient who works with us, and we videotape it, and then we do a debriefing. So it's been very good because in the real emergency room setting, it's not great to be criticizing the resident, and it's not the right time to be doing that. So this is a way we can do that better. Some of our residents have done that, and then the following day they treated someone with TPA, so it was really good. This is my segue slide of the cardiologist and the neurologist walking hand in hand. So I'm going to talk a little bit about risk factors. A lot of this is like preaching to the choir, because I know the people coming here are probably all doing these things. Now in our handout, we talk about risk factors. Those are the classic risk factors that you're all aware of, and these are very critical for preventing stroke. They say that about 80% of strokes are preventable, primarily blood pressure and smoking and treating atrial fibrillation with anticoagulants if appropriate. So there's a whole list of them. We have the little icons that represent these, and you can look at those later. I'm going to talk a little more about individualizing risk, but won't focus on these specific risk factors because I know they're getting some attention. Probably if we just all ate well, that would solve a lot of this. But this is just a Framingham stroke risk profile. So you've heard about the Framingham study. They did look at not just the risk of heart attack, but they developed a stratification system of stroke. And so looking at age and all the other risk factors, they could determine individuals' risk in general. So this was just a little example. So this is probably not someone in our audience here, but this is a 74-year-old male who's got bad blood pressure, 170 or so on average when they're assessed. And then they're diabetic, they're smoking, they have heart disease, atrial fibrillation, and some other things. So they're almost destined to have a stroke. So over the next 10 years, it's 88% risk. If you change a few things in that same man, here their blood pressure is treated and in the good range. They're not diabetic. They still have atrial fibrillation because Dr. Warrenberger hasn't solved that problem yet. But despite that, the 10-year risk is down to 13%. So it's very dramatic if you look at a 10-year period of time. I'm going to focus on the last part on the causes of stroke, and this is where I think stroke and heart attack do differ. It's what makes it interesting to me, day to day. So there's the risk factors for stroke, which lead to atherosclerosis and blood clots, but then there's the specific causes of stroke. And many of these are not related to those classic risk factors. So some people can just have really bad luck. They can fall down skiing, not to discourage you from skiing this weekend, but they can injure an artery and things like that. So I want to just highlight that. So sometimes you can do everything right, but you can still have a stroke. This is a picture of highlighting how strokes can be caused by things from basically the heart. Like here's a cross-section of a heart. You can get blood clots there. Or you can have blood clots in the heart higher up from atrial fibrillation. This is the aorta. And then this is just a picture of the brain cut like this way, and it shows all the little tiny blood vessels. So these are very delicate, but if one of these little tiny branches blocked off from thickening, it might not even be plaque. Arteries can just get thick and block off. That can cause you to be unable to move your whole side. So we see all different types of mechanisms or causes of stroke. This is another picture here. So we see cardiac conditions, cardiomyopathies, atrial fibrillation, aortic plaque, carotid plaque. You can have diseases that affect the back blood vessels, the vertebrals. You can have dissection or tearing of the vessel wall between the layers. You can have specific diseases that just affect the little blood vessels inside the head that are different than you see in the other arteries. You can see things that make your blood clot or hypercoagulable states. Certain medications, these are usually illicit drugs, not things that you would be taking. And then you can actually have strokes from the veins blocking off. So this is kind of different. I don't think you get heart attacks from venous occlusions. I've never seen that job. Okay, I'm going to talk about a few cases. So let me go to the middle section maybe over here. So these are just a couple of, these are real cases from our region, and they highlight a couple of things about the types of stroke. This was a 40-year-old smoker. He did not attend this conference. He woke up at 3 in the morning, and according to his wife, usually patients come because their wife tells them to come. He had difficulty speaking, and he appeared confused. He then looked like he was going to urinate in the bedroom. Then he shook his arm and his leg, and it seemed like they were not working right. And then she called 911, but then he seemed to be back to normal. He was able to walk downstairs, use the bathroom. When the ambulance came, he got weak again. So he was brought to the local emergency department. He had some mild weakness only. It was very minimal. It was like just a little bit of the hand. This was a hospital in southern Vermont, and that's a very small one, 25 beds total for this whole hospital. And so they called us, and we were able to have him come that morning right away. So this is an ultrasound of the carotid artery, and this is the vein here, and this is the artery, and it's very, very narrowed here. It closes down. This is a CAT scan angiogram. So this is a CAT scan with some intravenous contrast, and that shows you the carotid artery right here. So this is the carotid artery down low, and then when you get here, there's actually black things here. These are pieces of plaque and a blood clot in the lumen of the artery, and then it's open again up here. But these all are different blood clots. So this is one we call Dr. Residlow and her colleagues in vascular surgery, and I think he was one of the youngest endarterectomy patients we've ever had here. So this is not his picture, so I hope this isn't bad after lunch. But at 5:10 that same day, he had an urgent carotid surgery, an endarterectomy, and the quote from the surgeons was that they had a carotid plaque just at the bifurcation that went into the distal carotid. At the more distal end, he had newly developed thrombus, which was removed. So he did very well. He returned to normal. I understand that he later had an MI. So again, even though his risk factors, he had very bad cholesterol and he was smoking, he went on later to have a heart attack and was treated here for that too. So that's kind of a typical case. And one thing I like to emphasize is that the symptoms might be very minor. Like in his case, it was just a little bit of hand weakness when he went to the other emergency department. But he was sitting on like a time bomb, basically. And it's very hard to tell just from the story if he has that problem or not. So in neurology, we don't have like an EKG, a blood test for damage, so we're relying more and more on these other tests like the CAT scan angiogram to really know what's going on. So this is a second case. He was a healthy 61-year-old, maybe getting a little closer to the average age of this audience. And I think his wife made him do something up in a tree. He was trimming branches. I use this case to tell my wife how I shouldn't have to do things. He got confused after he fell out of a tree. So this was in August. He fell, he got a broken collarbone fracture and a little bit of what we call a pneumothorax, or a little puncture of the lung. And he was seen, got treated for that. He went home. The next day, he suddenly developed confused speech. So this was his collarbone fracture there. He had an MRI, and he had an aphasia when we saw him, and he had this is damage on an MRI, and I'll show you a little bit more about that fit with a certain kind of aphasia. So he was interesting. He had a heart ultrasound, and this is the right atrium, and this is the left. And what we do is we mix up some air in little tiny bubbles, and we put it in the vein of the arm, and then we can see those bubbles in the venous side of the heart, and we could see them going over to the left side of the heart with a little connection. So these are the little bubbles there that went from one side to the other. So this was a type of cardiac connection called a patent foramen ovale. If you like Teddy Bruschi, that's apparently what he had when he had his stroke. It's a very common finding in our stroke patients. So in his case, and this is why I wanted to emphasize this is kind of a perfect storm kind of situation, and it wasn't really related to any of the traditional risk factors. So he had trauma from falling out of the tree. He developed what we found was he had a clot in his leg vein because he also traumatized his leg. So he had to get a leg vein injury. He had a blood disorder, like you mentioned, but this was a special kind of thing we call an anticardiolipin antibody syndrome. So these are type of autoimmune things that promote clotting. And then he had this congenital heart anomaly that about 25% of the population has, that allows blood to go from the right side to the left side, and it's usually benign. I don't want you to worry. But it is a way for a blood clot, if it went up there, to get to the artery side of the brain. So he had that eventually treated. As far as I know, he did well after that. So this is kind of a typical type of case that needed a lot of different testing, and it was kind of it's not just one single factor. I'm going to take you back 45 years ago. Maybe you remember what you were doing. The field has really progressed. I don't remember the field then, obviously. I was a child. But back then, there were very limited tests that we could do for stroke. This was the way that angiography was done then. We didn't have the CAT scanner angiogram. This is they had to directly puncture the carotid artery to get a picture of the blood vessels. This is a skull, and they would inject air into the ventricles of the brain in order to see if things were being shifted from one side to the other. This is just a shunt that's unrelated to the problem that they had here. But the brain, normally these should be in the middle, so there was a mass there, and that would be one way of knowing if something is going on in the brain. So it's very limited. And then this is an EEG, where we can see how the electrical activity of the brain is on one side versus the other. So that was pretty much what we had back then, and that's just about the time John and I were little kids. This is a CAT scanner that started in the 1970s, and this is kind of a current CAT scan showing a stroke here within a few hours, and then how it evolves over the next day or two. And then these are two examples, like I showed before. This is a typical ischemic stroke on a CAT scan, and this is a brain hemorrhage where the white is the blood causing the stroke. Now we have new MRI techniques that have just come out in the last several years, and one part of that is called diffusion-weighted imaging, because it relies on the diffusion of water molecules that normally goes in and out of the brain cells. And if there's damage to the brain cells and the membranes of the brain cells, the water cannot go in and out, so it doesn't diffuse normally. And so MRI is very simple in some ways. It's related to the protons in the water and how they move or not. So this is an example, a very unusual case. All they had was weakness of the right index finger. Their stroke is hard to see on some of the older MRI sequences, but then if you look at these newer ones, it shows up pretty easily as a little dot. So this has really made the stroke neurologist's job a lot easier, because it's very apparent, and you can tell that it's happened. This will show up as something bright for about 2 weeks. And there's a part of the brain right here that is just for controlling the hand. So this is another patient. This is one of my patients who had what was thought to be a migraine and a little bit of speech problems. You can see they have damage here in the left frontal lobe, and then they had a carotid artery blockage here. So we use an MRA. So this uses the MRI machine to look at the blood vessels. This is where the heart would be and the aorta. The carotid artery comes up here and then it stops. This is the normal one on the other side. So in this case, she was a young woman. She had a carotid artery dissection that produced headache and the stroke. So basically a stroke neurologist is like, you know, either Dr. Watson or Sherlock Holmes. And this is them seeing a stroke patient, I think, on the floor there. I want people to understand this because sometimes when they are evaluated for stroke, they don't know why we can't be more definitive, like what caused the stroke. Sometimes we don't know even if someone has every test possible. So this is a lot more common, I guess, than you might see in other medical conditions, you know, like a pneumonia or something. It's complicated, so you have to give us a little time to figure things out sometimes. So that's all I wanted to cover today. I can take some questions now, or we can go on to Dr. Residlo, and then I'll stick around for the other question session later. So I thank you.